Okay, the history is of Mr. X, 55-year-old shopkeeper, who is presented with complaints of pain over face, neck, right ear, and tongue.
So, what's the nerve supply of face?
No, the sensory supply is by the trigeminal nerve and its various branches. That is the ophthalmic, maxillary, and mandibular divisions of the trigeminal nerve.
Any part of the face supplied by anything else?
The greater auricular nerve supplies the angle of mandible.
Okay. And what about the neck?
Neck is C3 division, C3 spinal segment.
Okay. So you have got this patient, 55-year-old shopkeeper,
Yes, sir.
who complains of pain over the face, neck, right ear, and tongue.
Yes, sir.
So what else you want to know about this patient?
Okay, we have to know about a history of any fever or vesicular lesions.
No, there is no.
Okay, then we'll have to know about the sensations other than if he is able to perceive any touch sensations or any other sensations over his face.
No abnormality noted so far.
Any motor deficits like difficulty in there is a deviation of angle of mouth or difficulty in closure of eyes.
He does not have.
Okay, any deficit of sensation like deficit of taste sensation.
He has not noticed so far.
Okay. Any other symptoms, neurological symptoms like weakness of the body or.
He does not have any other neurological complaints.
Okay, sir. Any hearing loss or tinnitus?
He does not have hearing loss. He doesn't have tinnitus.
Any history of double vision?
He does not have. But he has pain in the throat also. Neck, throat also. Okay.
Okay, sir. Okay, what causes the pain? Like if the pain is present throughout the day or any inciting event is there?
Yes, pain increases on swallowing. In between,
Okay.
he's all right.
Okay, then associated any hoarseness of voice, dysphagia?
He has developed hoarseness of voice, minimum dysphagia, if at all.
Okay, what was this?
Dysphagia described as food sticking in the mouth only, sides of the mouth, cheek, like that.
Okay, sir. Okay. So there is a dryness of mouth.
He has not noticed so far.
Okay, sir. The duration of all these symptoms?
It's 2 months now.
2 months. Okay. The type of the pain over this face is
Very severe, shooting,
shooting. Okay,
lancinating pain, shock-like pain.
Okay, sir.
When he swallows, he gets this pain.
Okay,
in between, he is absolutely well. Pain in the throat, pain in the upper part of the neck, right ear, base of the tongue, and increasing on swallowing. In between, perfectly all right.
Okay, sir. So his sensations over his face is normal.
Normal. On history is normal.
Okay, sir. Okay.
Would you like to, with this history, are you able to come to a differential diagnosis or possibilities?
Yes, sir.
What all possibilities comes to your mind?
Okay. So this is predominantly affecting the sensory supply of the face. So this could be a lesion affecting, that is the sensory supply of the face is mainly by the trigeminal nerve. And also, okay, so that could be a trigeminal neuralgia.
So how do you get pain in the tongue? What's the relationship between swallowing and trigeminal neuralgia?
The sensory supply of tongue is by the mandibular division of the trigeminal nerve.
What's the relation with the swallowing?
Um, it
Okay,
could
tell
be
me.
due to this dryness of mouth. Xerostomia could be a problem.
Can you tell me what are the common causes of pain in the head and neck? The description is already given to you. What is the differential diagnosis? One you already said trigeminal neuralgia. Any other
Yes, sir.
possibility that comes to your mind?
Herpetic neuralgia can be there.
Herpetic neuralgia can be there. Okay.
Um,
That neuralgia is usually confined to that branch which is commonly involved.
yes,
But
sir.
there is no history. There is no history.
Okay, sir. Um,
Okay, let us move forward. Let us move
okay,
forward.
Sir. Okay, sir.
Okay. So, pain is episodic, transient, piercing, lasts for seconds, comes on swallowing, radiates to face, upper neck, ear, and underside of the tongue, and no accompaniments, and in between is perfectly all right.
Okay, sir.
So, what is neuralgia? You said trigeminal neuralgia. So, what is meant by neuralgia?
It is the typical pain associated with a nervous lesion, nerve involvement.
So, they are usually electrical,
Yes, sir.
shock
Lancinating.
lancinating pain.
Yes.
Lancinating pain. So, what is the difference between neuralgia and neuropathy?
Neuralgia is the pain, the symptom is the pain predominantly, whereas neuropathy is any pathology associated with the nerve.
So, neuralgia is basically a pain along the distribution of the nerve, but neuropathy means loss of function.
Function, yes.
So, how do you recognize it? You already mentioned transient, extreme pain, lightning, piercing. So, how do you recognize? Name some common neuralgias.
So, trigeminal neuralgia, postherpetic neuralgia.
Trigeminal is related to the anatomy, and herpetic is related to the etiology.
Yes, sir.
Any other neuralgia you know of?
So, sciatica.
Sciatica. No, in relation to head and neck.
Okay.
This is a question you must ask me, and I'll give the answer at the end of the discussion.
Okay, sir.
Not now. Okay.
Okay, sir.
So, describe the trigeminal neuralgia.
Okay, the trigeminal neuralgia is the typical lancinating pain that the patient experiences in the face, and that is typically precipitated by actions like chewing or any sensory exposure like cold exposure, cold wind or that is blowing on the face, and that is the typical presentation. Usually, yes, sir.
Yes, carry on.
Usually towards the side of the face.
Right. And there will be something called trigger spots.
Okay, sir.
This patient does not have pain on chewing food.
Okay, sir.
If the mandibular division is affected, trigeminal neuralgia, you get pain on chewing.
Okay.
Ophthalmic and maxillary will be sensory.
Okay, sir.
So trigeminal neuralgia is a disease of the old people.
Okay, sir.
Okay. What is neuralgia intermedius? That will come later on. You remind me at the end, I will tell you.
Okay, sir. Okay.
How to investigate them, when to investigate them. Trigeminal neuralgia, when do you investigate? Commonly it is idiopathic and you don't investigate. Okay, but sir, if it is refractory to common medicines given like carbamazepine, then you have to go for imaging. And okay, you may get some tumors in relation to trigeminal nerve or some vessels pressing on that.
Yes, sir. Yes, sir.
We had a case of meningioma presenting as trigeminal neuralgia. So that is also possible.
Okay, sir.
How and when to investigate them and they don't respond to treatment.
Okay, sir.
Okay. How to treat neuralgic patients? What are the drugs we have got in store?
We can use drugs like, hello?
I didn't hear that.
Okay, we can use drugs like gabapentin.
First drug will be what?
NS.
Not NSA, it's something
Mm,
else.
anti-epileptic drugs like
That's right, that's right.
okay,
Like
carbamazepine.
carbamazepine is a good drug. But what are the important side effects of carbamazepine?
Um,
It's a good drug, very good, excellent drug. What is the side effect of that?
it can cause electrolyte abnormalities like
More life-threatening some side effect?
Steven Johnson syndrome.
Yes. What else? Toxic epidermal necrolysis.
Oh,
Can it produce stress syndrome? So they can have all those funny side effects.
okay, sir.
Granulocytosis, liver dysfunction. So some problems are there like that. Okay.
Okay, sir. Okay, sir.
Then what else? Any other drug?
Uh, Other drugs like gabapentin.
Amitriptyline,
Amitriptyline.
gabapentin. Okay, gabapentin. So drugs are there.
Okay,
So that's
sir.
how you treat. And if they don't respond, you go for rhizotomy
Yes,
or
sir.
injection of alcohol. Okay. So
Okay, sir.
surgical treatment is also there. Medical is there. Okay. History of this patient is like this. Initially, is on the hoarseness of the voice, dysphagia, periauricular pain, headache, progressive dysarthria, pain on swallowing. So couple of symptoms are there. Initially is an onset.
Okay, sir.
What are the condition neurology? Initially in onset.
Can be an infectious cause.
Infectious cause, yes. Inflammations,
Infection.
infections, demyelinations are all initially on.
In serious.
Degenerative,
Uh,
neoplastic,
mo-
they are all initially onset. No?
okay, sir. Okay.
Hoarseness voice. Which part of the body you think is the problem?
Can be the vocal cords.
So which nerve you think is a troublemaker?
Um, the recurrent laryngeal nerve.
Recurrent laryngeal nerve is a branch of
Vagus.
vagus. At what level it branches off?
Um,
Okay, simple question. If you have a lesion of the medulla, like lateral medullary syndrome, do you expect hoarseness voice?
no, sir. No,
No?
sir.
Why?
No.
You can have. Recurrent laryngeal is only branch, no?
Okay, sir. Okay, sir. Yes.
So it can be anywhere. So
It's
what symptom you lost this patient?
in a patient with hoarseness of voice.
Whom you think is having 10th nerve? What are the
Okay.
questions you want to ask?
Okay, history of nasal regurgitation.
So if there's nasal regurgitation, where can you localize? Yeah, be higher up. Just be higher up, not lower down.
Okay, sir.
So we don't expect a cause in the like bronchogenic carcinoma
Hmm.
to produce nasal regurgitation.
Okay, sir.
So causes inside the chest is ruled out anyway.
Hmm.
No?
Yes, sir. Yes, sir.
Yes. Then he has got dysphagia.
Okay.
Would like to ask more details about dysphagia?
Yes, sir.
What do you want to know?
Dysphagia to liquids or solids.
It is for both actually.
Okay.
More for solids.
Is it a painful dysphagia or?
Yeah, he
pain?
said, when he swallows, he gets a pain.
Okay, sir.
Any other details you want? Anatomically, where is the dysphagia? Can you tell me?
The pharynx.
Why do you say pharynx?
That is where the deglutition.
But the patient says the food is sticking in the cheeks. What does it mean?
There
And
might
he is
be.
using his finger to push the food back to the throat. What does it mean?
There might be a weakness of the tongue or
So
they could
oral phase of
deglutition.
swallowing.
Okay.
There's a different phases. So history was, I was telling from the beginning, the food is
Okay.
sticking in the mouth only.
Yes, sir. Yes, sir.
So it is oral dysphagia.
Okay, sir.
So you think the tongue is at the trouble, is it?
Yes, sir.
So what are the symptoms you lost in relation to tongue?
Um, Okay, we can ask about any history of apnea or breathing difficulty while sleeping due to the falling back of the tongue.
Anything else?
Um,
What is the other function of tongue other than swallowing?
Talking,
Talking.
speech abnormalities,
So how will you recognize tongue problems in speech? What
uh,
are the sounds produced by the tongue?
guttural sounds,
Guttural? Guttural is produced from the throat.
l-
Labials are
lip,
produced from the lip. What
lingual,
sound? Lingual. Which are lingual? Tell some linguals.
L,
La,
la, yes,
la, ta, ta.
ta, yes, sir.
So you can recognize the tongue is at fault. And this man is having headache, progressive headache also.
Okay, sir.
What do you think?
Um, Again, the trigeminal nerve could be involved,
No,
or
after some time he started developing progressive headache. That
okay,
is
oh,
continuous.
could be a vascular phenomenon.
Vascular headache. Which is vascular headache you know of?
Um,
Vascular headache is migraine. No, this is not
yes,
age
sir.
for migraine.
Yes,
When
sir.
somebody at the age of 55 has headache, you cannot think primary migraine. You may think secondary migraine. Migraine to some other primary cause.
Okay, sir.
Okay. So, on examination, we are going to get findings.
Okay.
Please read the findings.
On examination, the palate is not moving on right side.
Diagnosis. Diagnosis.
The palsy of the vagus nerve,
Vagus nerve. So, vagus is paralyzed on right side.
right side.
Yes.
Gag reflex is absent on the right side.
Tell me how to elicit gag reflex.
Okay. Ask the patient to open his mouth wide open and take a swab and gently touch the palate, and we'll see arching of the palate. Yes, posterior pharyngeal wall or the palate, and we can see the patient gagging with arching of the palate would be seen.
So, that is absent on the right side.
Yes.
What do you make out of that?
Again, a palsy of the 10th nerve.
What is afferent? What's afferent? Posterior pharyngeal wall supplied by what?
Glossopharyngeal nerve.
Glossopharyngeal nerve. So it can be either of it.
Yes, either.
Sternomastoid is weak on right side.
Okay. Again, a spinal accessory nerve palsy could be possibility.
Spinal accessory could be in trouble.
In trouble.
Okay, so we have 9th, 10th and 11th. And
Yes,
the
sir.
wasting and fasciculation of tongue on right side.
Yes. Hypoglossal nerve palsy.
Hypoglossal nerve is okay. Then what happened is he has got,
Winging of scapula.
yes, what do you make out of that?
There is paralysis of the serratus anterior.
What is the differential diagnosis of winging of scapula?
It can be in winging of scapula can be seen in paralysis of the serratus anterior muscle.
Any other condition producing winging of scapula? How do you elicit the
trapezius? Yes, sir.
trapezius?
Again,
The trapezius
spinal
is supplied
accessory.
by spinal accessory nerve.
Yes,
So what do you make out of now?
okay, so there is paralysis of the 9, 10, 11, 12, 12 nerves.
So what is the diagnosis here?
It's a medullary lesion.
Okay. The question comes, in medullary lesion, what else you expect? So medial medullary lesion or lateral medullary lesion?
Lateral medullary lesion.
Where is the nucleus of 12th nerve situated in the medulla? Laterally or medially?
Laterally.
No, just adjacent midline.
Okay, sir. Okay, sir.
Just adjacent midline. So if you look at the cross section, it is quite midline, not very far off.
Okay, sir.
So they are a bit away each other because the two 12th nerve nuclei are very close together. Commonly the disease affects both sides together.
Okay.
if it is a medullary lesion. And medullary lesion also contains some fibers to cerebellum. No?
Okay. Okay.
There are
Yes, sir.
sympathetic fibers.
Mm.
There will be pyramidal fibers. There will be sensory tracts. They are
Okay,
also
sir.
layered.
Yes, sir.
So can you tell me how to recognize a lesion inside the brainstem and outside the brainstem? Inside brainstem, important features are internuclear ophthalmoplegia,
Okay, sir.
crossed hemiplegias.
Okay.
You have got dissociated sensory loss,
Okay,
involvement
sir.
of sympathetic, long tract signs. They will all be helpful to say whether it's intrinsic lesion or extrinsic lesion.
Okay, sir.
So where can you put the lesion now?
This can be an extrinsic lesion since there is no involvement.
So where
No.
these nerves all come together? So they are, you are right.
The jugular foramen,
Carries what all things?
the 9, 10 spinal accessory nerve.
So what about 12th? How does 12th comes out of the skull?
Uh,
Which foramen?
uh,
Hypoglossal canal.
yes, hypoglossal canal.
How close is jugular foramen and hypoglossal canal? They are very close together.
Okay.
They are very close together. So
Okay.
lesion outside can compress both structures. So anatomically you can localize the lesion outside the skull, just outside the skull, encompassing both structures coming from hypoglossal canal and jugular foramen. What
Okay,
else
sir.
jugular foramen contains other than the nerves?
The jugular bulb,
Of what?
the internal jugular vein.
Yes. So that is also compressed. What will happen?
Yes,
What is the symptom of the patient?
Um, headache. Yes, sir.
Headache.
Yes, sir.
So this gentleman had a headache.
Yes, sir. Yes, sir.
So retrospectively, what do you think is the reason for his pain?
It could be a mass lesion.
This is what is called as Glossopharyngeal Neuralgia. The moment the patient says, I got pain only when swallowing, in between I am alright, you should have picked up the diagnosis of Glossopharyngeal
Okay.
Neuralgia.
Sir.
Okay.
Sir. Okay.
So what is the differential diagnosis here? Glossopharyngeal Neuralgia is the diagnosis.
Okay, sir.
Usually it's a primary idiopathic, but secondary causes are there like
Demyelination.
a demyelination will be usually confined to that particular nerve. But
Okay,
here
sir.
you have got a couple of nerves,
Yes, sir.
mass lesions, no?
Yes, sir. Yes, sir.
Carotid body tumor,
Yes, sir.
metastasis. So CP angle, these are the causes.
Okay, sir.
Middle ear infection can also produce problem.
Okay, sir.
Peritonsillar lesions can have same problem. If the base of the meninges is affected by granulomatous meningitis, all these nerves can be trapped.
Okay, sir.
If the carotid sinus is aneurysm, again you may have all the problems. So demyelination, mass lesions, metastasis, carotid tumor, okay, vascular causes, middle ear infection. Vascular means some vessels will be dilated and pressing on the nerve.
Yes. Okay, sir.
So what will be Eagle syndrome?
Due to the long styloid process, that is.
That's right. So Eagle syndrome or pressure by vessels is one of the common things. Basically vascular pathology, some entangled vessels and so on creating problems. This is called secondary. So obviously we'll have to, how do you examine 12th nerve?
Okay, sir. The 12th nerve is the hypoglossal nerve, so we can do the functions of the tongue. So first we can ask for the protrusion of the tongue and look for any deviation of the tongue.
Right.
So if there is a paralysis, there is if there is a lesion of the hypoglossal nerve, usually the tongue would deviate to the affected side.
Yes. Suppose
Okay.
it's a supranuclear paralysis, like pyramidal lesion.
Okay, sir.
Which direction it will deviate? It will deviate to the opposite side.
Okay, sir.
Opposite side. Okay. So one is deviation you are talking about. Yes. What else you will do?
And we have to see for the power of the tongue.
Power of the tongue can be tested. What else you want to test?
Any fibrillations or fasciculations?
Fasciculations can be looked at. How do you look for fasciculations?
Okay, ask the patient to open his mouth and not to protrude the tongue. That is, the tongue should be kept within the mouth.
And what does this fasciculations indicate to you?
It is a LMN lesion.
Yes. What else you will see in LMN lesion?
There will be atrophy of the tongue.
Wasting of the tongue.
Yes.
So you will find wasting of the tongue and fasciculation may be there. 1. 2. When you ask the patient to protrude, they are not able to do, or there may be deviation.
Yes, sir.
And then you are moving sideways. Second movement.
Yes,
Third movement will be ask the patient to roll the tongue upwards.
yes, sir.
And the third part of the examination will be looking for dexterity of the tongue by testing the linguals.
Yes, sir. Okay.
Linguals. Okay, right. So you look at the position of the tongue, appearance, power, dexterity, movements. Why the tongue deviates to the same side?
Due to the paralysis of the muscle.
So opposite genioglossus pushes the tongue to the side.
Yes.
Can you name the muscles of the tongue?
We have the genioglossus, hyoglossus, palatoglossus.
So how do you localize 12th nerve lesion? Supranuclear lesion, what will happen?
There will be a deviation of the tongue to the opposite side.
Yes. Nuclear lesion, what are the common causes? Inside medulla, what are the common causes?
Lateral medullary syndrome.
Yes.
Tumors.
Very rare. Motor neuron disease, polio, syrinx, neoplasia. Most important is infarction.
Okay,
unilateral lesion, what are the common causes? Neoplasia has different levels. Meningitis, trapping the nerve, or granulomas. Okay.
Okay, sir.
Couple of questions more. What is Jackson syndrome? This is question to Dilruba or team. Dilruba or team? Anybody there?
Yes, sir.
Just tell me something about Jackson syndrome.
Yes.
10, 11 and 12 coming together is called as Jackson syndrome. What is Collet-Sickert syndrome? They just like the patient we are describing, 9, 10, 11 and 12. What is Villaret syndrome? Same, everything together plus Horner syndrome. What is Tapia syndrome? 10 and 12. What is Avelli syndrome? Any idea?
No, sir.
Vocal cord and palatal paralysis plus some dissociation. And Schmidt syndrome? That will be homework. Okay, back to the 2 questions pending. Parvati, 2 questions we clarify at the end. What are those questions?
Yes, sir. So the types of neuralgia.
Yes, you tell me about that. Dilruba?
Sir, types of neuralgia.
In other words, differential diagnosis of pain in the head and neck, neuralgic pattern. Trigeminal neuralgia we said. Glossopharyngeal neuralgia, I provided the answer. There's a neuralgia in relation to nervus intermedius, and there's neuralgia coming in relation to vagus, and then we have got spinal nerve roots producing pain over there. Okay.
Yes, sir. Yes, sir.
So tell me something about nervus intermedius neuralgia. Neuralgia intermedius. What is mean nervus intermedius?
Nervus intermedius, it's also known as nerve of Risberg, sir.
That's
It's
very
part of
good.
facial nerve located
Yes.
between
Between
the motor and sensory component, between the motor component of the facial nerve and vestibulocochlear nerve, between
Okay.
7th and 8th nerve.
So it's the intermediate position. So when that is affected, where do you get pain? What type of pain you get? You get severe pain in the depth of the ear, associated with the trigger zone in the posterior wall of the external ear. So the moment you put your finger there, you get severe pain. So trigger zone is somewhere there. Okay. Treatment is same as before: carbamazepine, gabapentin, lamotrigine, baclofen. And then you have got microvascular surgeries and decompressive procedures. Okay. So summarizing, what is the case today we are discussing?
This is the case of glossopharyngeal neuralgia.
So step 1 is how to recognize neuralgia. Step
Yes, sir.
2 is to recognize each neuralgia separately. So this is actually a telephonic diagnosis you must be able to make. Glossopharyngeal neuralgia. Rest of the things are associations, and then you could localize, particularly where exactly is the lesion localized. Okay.
Okay.
So it is not that easy to make a diagnosis by investigation. It is not that easy to make a diagnosis by doing blood counts or CT scan. These are diagnoses that comes by taking proper history. So today's case is only a first year class for students to know how to recognize a neuralgic pain, and history wise how to focus or diagnose specific areas of neuralgia. Okay. And then of course how to examine 10th nerve, 11th nerve, 12th nerve. So Parvati will tell me how to examine the 11th nerve.
11th nerve, or the accessory nerve, has cranial and that's cranial accessory nerve. We have to test for the muscles that is supplied by this accessory nerve. That is the two muscles, sternocleidomastoid and also the trapezius. So for sternocleidomastoid, we can ask the patient to turn his head to a side against resistance. And we can see the prominence of the sternocleidomastoid muscles.
On the same side or opposite side?
Sternocleidomastoid.
On the same
Sorry,
side
sir?
or opposite side? If the right sternomastoid has to be tested, which direction the face has to turn?
Okay.
I am testing the right sternomastoid. Which direction that face should turn?
Left side.
Left side, that's correct. Simultaneously, you must palpate the sternomastoid, which you are testing. And trapezius you are testing by shrugging of the shoulder
Against resistance.
and winging of the scapula.
Scapula, yes, sir.
But then this technique of differentiating winging of scapula due to trapezius and serratus anterior, that can be easily done. This patient underwent imaging and was noted to have mass lesion.
Okay, sir.
Okay. So what is the difference between intracranial and extracranial lesions in relation to this jugular foramen syndrome? Jugular foramen syndrome can be intracranial or extracranial lesion. How do you differentiate?
The involvement of the spinal part or axis.
It is involvement of the 12th nerve
Okay,
and
sir.
cervical sympathetic. That gives a clue that it is outside the skull, not inside the skull.
Okay,
And
sir.
once you know it's outside the skull, again differential diagnosis becomes easy. Usually they are malignancies, primary or metastasis.
Okay, sir.
Okay. So I think that we come to the end of the class, but you can ask some doubts if you have got any.